Dr. Ken Landau. Thanks for watching. Let's continue our discussion of bipolar disorder. We've already talked about mania or hypomania. Now let's talk about depression. Let's talk about the therapy. So most people who actually present with bipolar disorder present with depression. Now there are subtle differences between unipolar depression and bipolar depression. Unipolar depression, people just have depression. Bipolar depression, two poles, so they have depression, but they also have the mania or the hypomania at some time. Now, there are no characteristics that we can use to really separate the two, but beginning in about the 1950s, there were some subtle features that were recognized. So, for instance, in bipolar depression, seems like there's an earlier age of onset. People have more frequent episodes, shorter duration. They have more abrupt onset and offset, and frequently it flares during the postpartum interval. Additionally, about 90% of the people with bipolar depression, as opposed to about 50% of the people with unipolar depression, have symptoms of hypersomnia. They sleep a lot. They have emotional lability, weight instability. They have psychoses or psychomotor retardation or even catatonia. When we talk about depression, the symptoms that are necessary to make the diagnosis are a distinctly low feeling or irritable mood or loss of interest, loss of pleasure. People eat more or less than normal. They gain or lose weight. They sleep either more or less than normal. They appear slow or agitated, complain of fatigue and loss of energy and feelings of worthlessness and guilt. They have difficulty concentrating, they're indecisive, and they oftentimes think of death or suicide. Now, you need a high index of suspicion because some of the symptoms are also present in conditions like the borderline personality disorder, PTSD, post-traumatic stress disorder, anxiety, or impulse control disorder. And some people have mixed mood episodes. Now, mixed mood episodes, remember, that's where you have symptoms of depression and either hypomania or mania at the same time. Now, the problem is that some people with mixed depression and hypomania or mania do not have bipolar disorder. So if a person has hypomania or mania and they have a history of depression, then they don't have unipolar depression. So you want to seek past episodes. It's important to establish what early life was like. Depression often begins prior to age 25. The number of lifetime episodes of depression, oftentimes more than 5. History of psychotic features with the depression, not only with mania, but also with the depression. And sometimes there's a family history of bipolar disorder. Well, in pregnancy, tends to flare, but there's a problem with the medicines. The medicines may have some adverse effect on the pregnancy. So it's important to counsel women prior to the time they become pregnant so you can decide what to do with the medicines. Oftentimes it's appropriate to taper some of the medicines, see if the person can get off of the medicines, but have to realize that during the postpartum period, especially in women who have the first child, then the symptoms of depression may well flare. And it's also important to realize that taking the medicine is probably not a good idea during breastfeeding. Now, during adolescence, about 60% of individuals show up with the bipolar disorder if they're going to get it, and they get it prior to age 21, oftentimes between the ages of 13 and 19, especially if the parents have a history of bipolar disorder. If they do, then the onset is going to occur at a much younger age. You have to realize that it can alter the development, the psychosocial function of these individuals. It increases the risk of substance abuse. They have difficulty with behavior, with academic progression. They sometimes have interpersonal problems or legal problems. Oftentimes think of suicide. During adolescence, they have cognitive and emotional immaturity, so that oftentimes they don't have the verbal expression so that they can express the symptoms that they're complaining of or that they manifest. And you have a difficult time ascertaining some of the key symptoms like grandiosity. Grandiosity is often very common in young people without any other kind of disorder. And young people oftentimes may present with mixed or rapid cycling. They have shorter periods of hypomania than in adults, and the symptoms of hypomania or mania may overlap with attention deficit hyperactivity disorder, an emerging personality disorder, behavioral disorder. In adolescence, frequently we find irritability and temper outbursts, and that can be a marker or manifestation of some psychiatric disorder, but it might just be the age of the individual. Now, the treatment of adults and children basically is pretty much the same, except the side effects of our therapies, especially the anti-psychotic drugs, more associated with the metabolic syndrome in younger individuals than in older individuals. Now, it's important when we talk about depression or we talk about mania, both in the bipolar disorder, that we talk about suicide, because there's a major problem with suicide in bipolar disorder. So if a person develops the condition at a younger age, now women are more likely to attempt suicide, but men are more likely to complete suicide. Minority youth more likely to suffer from suicide. Bipolar 1 associated with the mania more likely than bipolar 2 associated with the hypomania. Borderline personality disorder, single or divorced. Single parent, patient who has predominant depression, rapid cycling, people who also have anxiety or atypical symptoms. And then in addition, if a person has some other coexisting psychiatric disease, substance abuse, cigarette smoke, or a person's overweight or obese, they have a primary relative who has a mood disorder, they've had a previous suicide attempt, and we realize that the major risk factor for a completed suicide is a suicide attempt. Early life trauma, interpersonal conflict is enough oftentimes to throw people over the edge. So bereavement, if a person is discarded by a loved one, by a high school friend, that may be enough to turn a person into a suicidal ideation. And if we look overall at bipolar disorder, somewhere between a third and half of the people contemplate suicide, attempt it at least once during the course of life, and about 15 to 20% of the people who attempt suicide actually complete suicide. Now, death, not only because of suicide, but because of other reasons, occurs about 8 to 20 years prior to what it would be in the general population. Partly it's due to the suicide, but also partly due to natural causes. Natural causes because they have comorbid obesity or cardiovascular disease or metabolic disorders. So then we talk about the etiology. What causes the condition? It's multifactorial, which means we really don't know. It's part genetic and part environmental. So historically, it was thought to be due to an imbalance of what are known as the monoamines. Those are neurotransmitters like serotonin and norepinephrine and dopamine. But actually, they can't find any significant abnormality in those. But we think that somewhere between 70 and 90% of bipolar disorder might be attributable to some sort of a genetic abnormality. Identical twins, about 40%. Have the condition. Non-identical twins, dizygotic twins, about 5 to 6%. It's interesting that people talk about the environment, but if we look at children who are born to normal parents, parents without bipolar disorder, and they're adopted into families with bipolar disorder, those children don't suffer from bipolar disorder. On the other hand, if the birth parents had bipolar disorder, and now those children are adopted into families without bipolar, well, then the chances are going to develop bipolar disorder. Genetic searching, called genome-wide association studies, show that there are at least 30 different loci, 30 different genes that are abnormal in people who have bipolar disorder. That accounts for a sliver of all of the cases. Now, there's something known as the kindling hypothesis. The kindling hypothesis suggests that you have some stress sensitization, and that leads to some of the problems. So you have the first episode after some sort of stress, and then subsequent episodes can occur without any exposure. So you need just that first initial exposure. And in those people who are exposed to psychoactive substances, people with personality disorders, people who have lifestyle risk factors, people who smoke cigarettes, people who are sedentary, all seem to be at higher risk. Well, if we look at people who have bipolar disorder, and we follow them over a period of time, we find that they may develop some progressive changes in the brain structure and the cell function. And that means that people who have long-standing disease, people who aren't treated appropriately, may have some significant abnormalities in the brain that cannot be corrected. It's also suggested that maybe there are some epigenetic abnormalities or mitochondrial problems or neuroplasticity or oxidation or neuroinflammation, inflammation inside the brain, or maybe it has to do with the reticuloendothelium. Don't really know. But the concept of this kindling and the progressive course, that goes all the way back to Kraepelin in the 1920s. Well, there's some evidence that as bipolar disease progresses, there's a decreased response to the mood-stabilizing medicines. Now, when you see an individual for the first time, or even after a period of time, this is a totally quixotic condition. So you can't predict whether the person's going to have multiple episodes, going to have few episodes, going to have long-lasting or short-lasting episodes. To make the diagnosis of bipolar disorder type 1, you need at least one manic attack. Now, you don't really have to have any major depressive episodes. They're typical, but they're not necessary for the diagnosis. On the other hand, in bipolar disorder number 2, then you have to have at least one hypomanic attack associated with at least one major depressive episode. Now, there's the cyclothymia, where people have the condition for at least 2 years, but they don't really make all of the criteria. They don't meet the criteria necessary to make the diagnosis. Now, in some people who have bipolar disorder, even when they supposedly are getting back to normal, even during periods of remission, now we're finding that some of those individuals have poor performance on executive function, verbal memory. Seems to relate to the severity of the disease and how long the disease has lasted, how long the person's been ill, how many manic attacks there have been. So another reason to make the diagnosis relatively early and begin therapy relatively early. What kind of therapy? Well, most seek care at the general practitioner's office. What we want to do is we want to stabilize patients, get them functionally improved, minimize the side effects of therapy. We want to prevent the recurrence of the disorder. We want to evaluate the patient for safety because remember, again, there's suicide that's always lurking in the background. So is the person at risk for suicide? And remember, it's difficult to achieve full remission, only full remission in maybe 25, 30, 40% of the individuals. Some lingering symptoms, some of those neurocognitive problems may persist. Well, if a person needs for the acute behavioral emergencies, then a person might need hospitalization. Person, if they have violent behavior, might need some anti-psychotic therapy or some benzodiazepines. We know that valproate seems to be okay for the mania, okay for the maintenance too, not good for the depression. Lithium seems to be good for mania, may be good for depression, may be good, pretty much so, for prevention of recurrences, so it's good maintenance therapy. Tegretol or carbamazepine, that seems to be good for the mania, but not so good for the depression. Maybe okay, not great for maintenance therapy. And Lamictal, well, it doesn't seem to be good for the mania, maybe a little bit good for the depression, but seems to be much better for maintenance therapy. Now, lithium is the oldest mood stabilizer. It has a relatively slow onset. So people who have significant mania, they might need an antipsychotic drug to start with. Well, the lithium might be less effective in people who have the rapid cycling or people who have the mixed mania and depression. It decreases the risk of suicide. That's one of the for sure things it does. Blood levels are very important with lithium. Lithium has a lot of side effects, nausea and vomiting and tremor and thyroid disease and kidney disease. So you need to drink a lot of water. You need to have 8 to 12 glasses of water a day. You have to avoid dehydration. Have to be very careful if you suffer from vomiting or diarrhea. That might lead to severe dehydration, and that changes the blood levels of lithium, could lead to toxicity, and have to avoid the nonsteroidal anti-inflammatory drugs. So you don't want to take ibuprofen or naproxen without telling your doctor. There's the valproic acid, might need a loading dose. There's the tegretol. It's less established for the maintenance. It has a lot of drug-to-drug interactions, potentially serious hematologic problems, aplastic anemia, Stevens-Johnson syndrome, a skin rash that can be quite severe. Lamictal, well, it's not for the acute mania, but it might be good for maintenance therapy. So we look at the patient after 1 to 2 weeks. Person's not getting better. Consider change in the medicine. Oftentimes you need combination therapy. You need combination therapy with an antipsychotic and a mood stabilizer in children. Maybe the antipsychotics work a little bit better than the lithium or the valproate. But remember, the antipsychotics in children have a considerable increase in the likelihood of causing weight gain and diabetes and a series of other problems. Some people go for ECT, electroconvulsive therapy, bifrontal. It can be used either by itself or as adjunctive therapy. It's helpful in people who are refractory to therapy, people who don't seem to get better. If you have acute mania, some patients need hospitalization for stabilization. Need to restore normal sleep to these individuals. Nearly all of the people who are severely ill with acute mania that's bad enough to be hospitalized, they're going to take an antipsychotic medicine and a mood stabilizer to treat the mania. Antipsychotics themselves, probably better than the mood stabilizers, so people take the Seroquel or the Zyprexa or sometimes the Haldol. Haldol actually might be faster in action than some of the newer drugs. Then we have the lithium and the tegretol. Now, if you're not really severely ill, maybe just one drug is sufficient. But for most people, especially people who have severe illness, combination therapy is going to be much better tolerated, going to be required. Now, if a person doesn't have mania but has hypomania, what do? We don't have any good information on that. It's treated the same way as mania, but that might be too much therapy. So in people who have mania, several days to less than 3 weeks till the benefit. If they're not benefited by that period of time, then need to add other kind of therapy. Interestingly, some experimental evidence suggests that either tamoxifen, that's used for breast cancer prevention or breast cancer treatment, or allopurinol, that's a drug that's used for gout, when added to lithium, might improve the symptoms. Now, the antipsychotics, they're effective for the mania and for the psychoses. They're more rapid in onset. They can be used as solitary therapy. They help with mania. Few of them help with depression. Cariprazine and olanzapine combination with fluoxetine, Seroquel and Latuda seem to be quite helpful. Person has acute depression. Fewer options actually than treating mania. So we start off with a low initial dose. We increase gradually because remember, the antipsychotic drugs are all associated with significant side effects. So we start with the low dose of the Seroquel or the Zyprexa or the Latuda, or we use the combination of the olanzapine and the fluoxetine. Sometimes for people we get improvement with Lamictal. We don't use the selective serotonin reuptake inhibitors, Prozac, Celexa, Paxil. We don't use the SNRIs, drugs like Pristique, drugs like Cymbalta. Those drugs, they might have some use in people who have bipolar II disorder, but probably not for bipolar I disorder. Small studies have shown that maybe you get some benefit with ketamine or even Nuvigil. People who have depression also have been treated with anticonvulsants, sometimes drugs like gabapentin or Topamax or Trileptal. Well, if a person has had good response and now all of a sudden is breaking through and is having symptoms, especially with bipolar 1 depression, maybe the person's not taking an adequate dose. Maybe the person's not adhering to the medicine. Maybe it has a drug-to-drug interaction. Maybe the person started taking another drug and you don't know anything about it, and the person is taking an antipsychotic drug or antidepressant drug rather, or maybe the person is taking a psychoactive substance, an illicit type of a drug. Maybe the person's developed some thyroid abnormality, not uncommon if you're taking the lithium. Maybe the person's drinking too much alcohol, abusing substances. Well, adjunctive therapy in very small samples, some people find that there's some added improvement, not as sole therapy, but as additional therapy, maybe taking some of the polyunsaturated fatty acids or a diabetic medicine like pioglitazone. We can have other kinds of therapies, the psychotherapeutic approach with cognitive behavioral therapy or dialectical behavioral therapy or family-focused therapy or exercise. All seem to be somewhat helpful. Have to evaluate people over time as far as their blood sugar and their blood lipids and their blood pressure and kidney function. Preventive therapy. Well, most people are going to be on long-term therapy. Now, lithium is one of the most effective drugs that we know in the prevention of the mania and the depression. Sometimes lithium alone will be adequate to maintain remission. Sometimes lithium with another drug, could be with valproate, could be with Seroquel. Now, unfortunately, a lot of the studies have been funded by the industry, by the drug industry, by the pharmaceutical companies, and they hedge on the study a little bit. They hedge on the kind of patients that are taken into the study, and as a result, a lot of the trials, even though they present glowing results, well, we can't really depend on them. Now, if you stop taking the medicine, especially if you stop taking the medicine abruptly, then you can have the risk of a flare and a relapse, especially, as mentioned, during pregnancy or during the postpartum time period. So you have to make the decision before pregnancy. So basically, there you have it. We have 2 shows on bipolar disorder. We've walked you through where we stand at the present time as far as the diagnosis and treatment of disorders are concerned. Sad to say that we still don't have any firm biomarkers of the disorder, which means that if you go to 2 or 3 different doctors, you may well get 2 or 3 different diagnoses. So we don't have any standardization. And remember, a significant number of people are being diagnosed and treated by the family doctors, and those family doctors might lack some of the diagnostic and therapeutic acumen in some of the psychiatrists, but even among the psychiatrists, remember, they only have a limited number of drugs. And sometimes the drugs are given in a trial and error approach, which basically is a form of voodoo. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.